Kelly?
Yeah?
Are you set up?
Yes,
Okay,
it's going right now.
We're going. Okay. We're clear. Everything is so high. Does everybody want it? Oh well. That's all right.
In the middle right there, who's that, Janet? You guys are in the bottom, Janet. In the middle where you have one.
It's okay, friend.
No, you can't down more, Janet. All the way down, right there. Let's screw that.
Okay.
There you go.
Okay. Maybe it's too low for everybody now. I don't know.
There you go.
They can raise it.
Now,
Diana, are you available? Oh, you're there. Okay, good. Well,
You have
as soon as we get the recording going,
we can just pull it. I'm ready. Kelly's ready.
Oh, we're good. We're good. Yeah.
Okay, we're ready for our afternoon session here. If everybody could settle down, we got to get on with things because everything's important for everybody to hear. We don't want anybody to miss anything. So I want to introduce Diana Gray, who's from High Cap, and she's going to give us some really good information about a lot of things, Medicare and Medi-Cal, and a whole lot of stuff that will be really good for us to know. And thank you very much, Diana, for coming.
All right.
Hello, everyone. Glad you're all still here. I know after lunch it gets a little sleepy and people like to kind of go home, but I'm going to talk to you today about a number of things. I'm going to talk to you about Medicare, and I'm also going to talk to you about our agency. And let me start by telling you about our agency, which is Legal Assistance for Seniors and High Cap. And we provide many kinds of legal and Medicare counseling services for almost anybody in Alameda County. And by the way, what I'm going to talk about for us in Alameda County is also available if you live in Contra Costa County or some other county. Most of these services are available. So let me tell you first about Legal Assistance for Seniors, because Legal Assistance for Seniors can provide many different kinds of legal services for people. For instance, public benefits like Social Security, Supplemental Security Income, cash assistance programs for immigrants, and some other programs. If you need legal advocacy for any issues in those realms, then Legal Assistance for Seniors may be able to help you with that. And usually the services are at no cost. We also help with, as I said, health law like Medi-Cal, Medicare, private insurance. And I'll get to that in a minute, but if you were to see a Medicare counselor about your Medicare or Medi-Cal issue and it got really sticky, then it could go to our legal side. Also, elder abuse. Legal assistance helps with elder abuse issues, and of course we all know this is really kind of a hidden secret, but it is really important for you to understand that if you know anyone or you yourself feel like you're having any problems with elder abuse, you should definitely talk to someone about it. You can always call our agency and talk about it anonymously if you like, and see if you would like us to help you with it. And abuse, the legal side can help with restraining orders. We also can come out and talk to you about preventing physical, financial, and emotional abuse. And don't forget also that part of the abuse issues is regarding self-abuse. We sometimes won't take care of ourselves like we should rather, because we don't think we can or we need help. So we can give you some ideas about that as well. Relative caregiver issues. If you're a step-parent or a grandmother taking care of grandkids or aunts taking care of nephews, and you need help with legalizing that and getting financial support for that, a legal assistance for seniors also does that kind of thing. Advanced healthcare directives. Now, we all know that as we get older, certain things become more important. And one of the really important things is to have health care directive which you can designate someone to make decisions for you if you're not able to anymore, or in case of an accident or something like that. And we can help with that. As I said, we can come out and do presentations on any of these issues to any group that you belong to, by the way. If you belong to other groups and you'd like us to come to your church group or whatever, we can do that. Also, conservatorship. Legal Assistance for Seniors works with the courts in Alameda County to help with conservatorships, and by representing people who are proposed to be conserved. If you know someone who is going to be conserved or threatened to be conserved and they don't think they should be, or the other way around, then legal assistance can help with that. So I encourage you to please call if any of those things ring a bell for you, or you know anyone that kind of thing rings a bell. And by the way, some of you folks out here are more knowledgeable than I am about some of the issues I'm going to talk about. So please interrupt me if you hear something that's iffy, or if I've misspoken something. I have a hand up here. Yes.
Could you just say it out loud because everybody got a mind? The telephone number, you know, we have memories, you know what I'm saying?
Yes, thank you.
Say it loud.
The phone number to call. And by the way, you'll be able to get these telephone numbers time and time again. So I'm going to say them right now. The phone number for legal services is 510-832-3040, and the telephone number for Medicare and health insurance issues is 510.
Wait, we're going too fast, we blind.
I'll say them again, 510-839-0393. And I'll say those again later. In fact, I'll say them many times, so hopefully you'll be okay. So let me talk to you. Yes, ma'am. You sure can. Oh, by the way, I forgot to tell you that over here on the piano, I do have handouts. And some of them are in large print. There are a couple of CDs. This is all about Medicare and Medi-Cal. And there are some things that are not in large print and not in CDs. So if you have caregivers or family members that we want to take these home and have them read them for you, you can do that. So let me, we do have the phone numbers on paper. So let me just talk to you quickly about Medicare and other health insurance. The HICAP program provides one-on-one counseling for people who have questions about Medicare and other health insurance at no cost. The HICAP program does not endorse or sell any insurance products. That's not what we do. We are a program that is funded by the state and federal monies, and we are mandated to remain unbiased. So if you come to us to get information, you will get a complete picture, because that's what unbiased means. If you should go to an insurance agent, let's say, you will get good information, but it may be limited. If you come to a HICAP counselor, you will get the full, entire picture about what's going on with your circumstance. So, Medicare. Oh, by the way, the HICAP program has around 30 different locations around Alameda County. So we can make an appointment someplace near you that's going to be at a convenient time and day for you to be able to sit down and talk about your issue. Yes? We are no longer located downtown. We are located at 30 different locations around Alameda County. So when you call to make an appointment or ask a question, we will be able to try and figure out something that's close to you at a day and time that's close to you. We do not do walk-ins. We also do not do Medi-Cal only. We only talk about Medi-Cal if you also have Medicare.
Oh.
So Medicare, and people get Medicare in a number of different ways. Now Medicare, you can have Medicare if you have been receiving SSDI for 24 months. Then you can have Medicare. And I will tell you that a lot of people have Medicare already and they do not know it. So 24 months of SSDI, or when you turn 65. 65 is the age for Medicare. Social Security is a different age. When you were talking earlier about that switchover from disability to age and disabled pension from Social Security, it's different ages now. It's 66 and a half or 66 and 3/4, or it depends on how old you are and when you get there. And also, there are other ways to get Medicare, and that is if you have a couple of specialty diseases like Lou Gehrig's disease, or if you have end-stage renal disease. So there's great benefits for you if you have any of those things. You don't have to wait till the first couple of criteria that I mentioned. Now, one of the things that people don't understand about Medicare, it's a very common misconception, that Medicare is free. Medicare is not free. Medicare costs money. There are certain co-payments and deductibles. For instance, if you have Medicare only and nothing else, and you had to go in the hospital, they would ask you to pay over $1,000 out of pocket. That's if you have no other secondary insurance. Also, when you go see if you use the medical part, you go see a doctor or get an x-ray, you would have to pay 20% of that. And 20% of a $6,000 test to look at your stomach can be a lot of money. So what do people do about that? Well, there's a number of things you can do, and I'm going to go into some detail, but I'll tell you quickly that you will need to have some kind of secondary insurance, and there are programs that will help pay for some of the costs in Medicare and some of the secondary insurances. But let me go back up a minute because I want to make sure you're clear about Medicare. Medicare and Social Security are not the same agency. They are separate agencies. Social Security does Social Security and disability. Medicare does health insurance. The only thing that Social Security has to do with Medicare is they will sign you up for it. So if you need to sign up for Medicare, you either need to go to the Medicare website, the Social Security website you sign up, or you need to go to a Social Security office. But after that, if you really want information about your Medicare, you can ask Social Security, but they may not exactly have the right answer. That happens. So you need to get the answer from Medicare. And if you call Medicare, they will very often refer you to HICAP program in your county. Now, by the way, the HICAP program is actually called the State Health Insurance Program in every state and territory in the U.S. So if you have relatives living in Tennessee, they can have the same kind of program. So Medicare costs money. I've just explained some of the costs. There are more costs. So what do people do about that? They get some kind of supplemental insurance. And there's many ways to do that. There's basically 5 ways to supplement the Medicare so that you can get those costs covered. And all of the ways to supplement Medicare have time frames that you can or cannot enroll. They have different costs from $0 to $600 a month. They have different criteria for when and what they pay for. One of the ways that you can use, get help with some of the Medicare costs is if you're a veteran. If you're a veteran and you sign up for VA care, the two programs don't really talk to each other, but they do help each other out. Another way you can supplement Medicare is by getting what's called a Medigap supplement program. That is a special health insurance, private health insurance, and it only pays what Medicare does not. So if you use your Medicare and there's some left over that you're being billed for, then this Medigap supplement policy will pay the rest, depending on what kind of policy you get, and depending on how much you can afford, and depending on whether or not you initially saw a Medicare provider. If you did not go to a Medicare provider, these policies will not pay. Another way to supplement Medicare is with what's called a Medicare Advantage plan. And in Alameda County, the only Medicare Advantage plans we have right now are HMOs. Now, the HMOs cost less than some of these other programs for the monthly premium. However, they all have co-payments and deductibles for every service that you get, except in a couple of special circumstances, which I will get to in a minute. Another way to supplement Medicare is with, what did I leave out here? Let's see. No, that's the name of a company. That's not a type. That's covered under all of these. So yes, the other way is with low income assistance programs. For instance, Medi-Cal is a good way to supplement your Medicare. I'm going to tell you a couple of very important things about that. Number one, if you have Medi-Cal first, and then you get Medicare, everything is going to change. Everything's going to turn around and flip around, and you will still be fully covered. However, things are going to change in how you get that coverage and where you need to go. And there are different kinds of Medi-Cal. If you have Medi-Cal with no share of cost, that means full Medi-Cal. I am not talking about the Medicare now. I'm talking about just the Medi-Cal. Then, if you have Medi-Cal with no share of cost, you have certain privileges. If you have Medi-Cal with a share of cost, then some of those privileges you have to pay for. So, right now, I'm going to talk about the Medi-Cal with no share of cost and your Medicare. Okay, you've had Medi-Cal for years, and they've been paying for your drugs and all this other stuff, and suddenly you get Medicare. Everything changes. Medi-Cal is not your primary insurance anymore. It is not. Medicare is your primary insurance. And you have to go see Medicare providers. Or you may end up paying for something. Oh, you know what I forgot to tell you about before we continue with that? I forgot to tell you about the different parts of Medicare, okay? There are all kinds of different parts of Medicare. Medicare Part A is the hospital part, or any other institution, like skilled nursing facility, not custodial care, but therapy care, and also hospice, which is a great hidden benefit of Medicare. Some of the other institutional things, that's the Part A Medicare. The Part B Medicare, B as in boy, is all the medical things. The doctors, the x-ray, the lab tests, some of the supplies that you get for some of your ESRD or diabetes and not others, only some, one way and some the other way.
That's a real one.
And then there is Medicare Part D as in drug. So once you go from Medi-Cal to Medicare, your Medi-Cal will ask you to get Medicare drug coverage. Now, one of the tricky things about that is, sorry, is that when you had just Medi-Cal, they were paying for your drugs. And what they were doing actually was, there is a co-payment for drugs on Medi-Cal, but they never charged it to you. Because administratively, it doesn't make any sense for them to charge you for it, because it's only $1 and it's going to cost them $3.50 to process the paperwork. So you did have a co-payment, but they never asked you for it, so a lot of people think they did not have a co-payment. Now you have Medicare, and your Medi-Cal is going to ask you to get your drug coverage through them, and you will have co-payments for every drug you pick up at the pharmacy or get mailed to you. So that's one of the changes that happens. There's also a monthly premium for the prescription coverage. There's also a monthly premium for the Medicare Part B as in boy. And what I'm going to talk about in a minute is certain programs that will pay those for you. But let me go back now to the supplementing the Medicare and why you might want to do that and ways to do it. So one of the important things for you to know, especially if you're going to ask help from anyone that you're speaking here today or anyone else you know about or the HICAP program, you're going to need to know what type of insurance you have. Kaiser is only the name of a company. It does not tell us the type of insurance you have because Kaiser has about 16 different types of Kaiser in Alameda County. So what type do you have? You have Kaiser through Alameda Alliance for Health in your Medi-Cal? Or do you have a Medicare, Medi-Cal Kaiser? Or do you have a Kaiser from your retiree plans, if you were? Or do you have I could go on and on. So all you need to understand is that there's different types, and you'll need to know what type it is that you have if you need help. Now, there are many other company names that you'll hear that are supplementing Medicare, but they all fall into one of the types that I just told you about. A retiree plan, a union plan, a Medi-Cal plan, a Medicare HMO. There's health nets and Aetnas and Kaisers, and none of that matters because they all sell different types of plans. So you're going to need to know that. You would also need to know what parts of the Medicare you have or not. And I'll tell you, there are many people who have Medicare and do not know that they have it now. So it's easy for us to help you find out if you have Medicare, if you want to call us. Okay, let's see, where was it? Oh, let's talk about the plans to help you pay. I heard somebody earlier talking about the Medicare Part B as in boy monthly premium. There are some plans that will help you pay for that monthly premium if you qualify under income and asset levels. So the first thing we would do if you call us is to check with you. Where does your income come from? Where does it fall? Some of the income is counted, some is not, in determining whether or not you qualify for these programs that will pay the Part B boy Medicare for you. So there is that program that you could call us to see if you qualify for. Some of those programs also pay the hospital deductible I just told you about for the Part A that's over $1,000. Some of them also pay for the 20% co-insurance for Medicare Part B as in boy that I was speaking of earlier. So anytime you're being charged something, please call us and find out, is this correct or is this wrong? Now, some of the other things that you might see, let's talk about the Part D and the charges for that. there is a program that will pay for your Part D drugs, monthly premium, and most of the co-payments if you qualify under income and asset levels. So once again, if you're being charged $40, so you go to the pharmacy and they want $40 for some drug, something might be wrong. So you can call us before you pay for it and find out what's up with that. Now let me say another thing about the Part D drugs. Medicare recommends that every year in November, you do a reevaluation of the prescription drug plan you have now, because it will change in January. Every year, every plan changes in January. But HICAP can make it really easy for you. If you call us in November, we will do a comparison of all the plans there are out there, all 28 or whatever there are in California, and give you information that will show which one is the most cost-effective that has your drugs on its formulary. So we can do that for you, and Medicare is recommending that you do that every year. You can sometimes save $400 or $500 a year. Sometimes you can't. Sometimes it's best to stay with the one you got. But if you would like us to do a comparison, we can do that. Now, the Medi-Cal, as I said earlier, there's different kinds of Medi-Cal. There's Medi-Cal with a share of cost and Medi-Cal without a share of cost. And if you have full Medi-Cal with no share of cost, and this is another thing you need to know if you come to get help from anybody, whether it's HICAP or the case manager or whoever. You'll need to know if you have Medi-Cal with a share of cost. And if you do, all different rules apply. If you do not have Medi-Cal with a share of cost, if you have full Medi-Cal in Alameda County, you can have it in 3 different ways. You can have straight Medi-Cal, it's called fee-for-service, or you can have your Medi-Cal under Alameda Alliance for Health, or you can have your Medi-Cal with Anthem. And you have a choice. Sometimes people get their card and they say, we put you in Alameda Alliance for Health. Well, you have a choice. You can stay with that if you like, and there are advantages. Or you could switch to Anthem, and there are advantages there. Or you could stay with just Medi-Cal straight fee-for-service, and there are advantages there. So if you want to know details about this, you can call us, make an appointment, and we'll talk to you about it. And I know it may be sounding complex now, but trust me, when you sit down with a counselor, it can become very organized and much more simple than what you might be being confused about now. There are also other special Medi-Cal programs for certain disabilities and certain medical conditions, and so there's all kinds of different kinds of Medi-Cals. That's why it's really important for you to know that. And while I'm thinking of it, let me tell you, do yourself a favor. If you have Medicare, please go online, or get your grandchild or whatever to go online for you, and go to mymedicare.gov, not medicare.gov, mymedicare.gov, and get yourself an account. It's going to make it really easy and fast for all your other programs. When you need paperwork, you can go there and print it out right away. And for us, it becomes really important. Also, go to the Social Security website and make yourself a Social Security account online. And that, you know how many programs are you in, housing and whatever else, and they say, we need your Social Security statement to see if they're taking the Part B premium out or how much you're making each month. You can go there and print it out instantly.
Wow.
So do yourselves favors and try and get that. Of course, it is the internet, and we all know that things happen with the internet, but just be aware of that. So there are other special programs, as I said. One of the really great things about the Medi-Cal is the Medi-Cal for long-term care. So if you should ever have to go into custodial care in an institution or other kinds of institutions, then your regular Medi-Cal would be switched over to the Medi-Cal for long-term care institution. And if you're low income and your assets are low, it will pay for most all of that. So there's all kinds of different programs out there to help you pay for these expenses. Speaking of which, one of the websites that you could go to that's extremely helpful is benefitscheckup.org. It's a great website, and you put in your information and it will come up with a list of all kinds of programs that you might be eligible for to get help paying for phones, paying for heat, paying for all kinds of things. I always want to mention that. Let me see, what else am I forgetting here? How about some questions? Somebody had a question over there? Yes, ma'am.
Medicare, is this the red, white, and blue card you're talking about?
Yes, thank you. The white paper card with a red and blue stripe. That's your Medicare card. And that's your number one card. Your Medi-Cal is only secondary. Your primary insurance, once you get Medicare, is that card. And guess what? This is giving me a chance to talk about fraud, because the fastest growing crime against seniors right now is, well, it used to be, it might be second now, is identity theft. Who's got a Medicare card here? Can you bring it out? Can you bring it out? And tell me what you see on there. It's the white paper card with the red and blue red and blue stripes.
Oh, I know it perfectly. I know it.
And what's on the front of that card?
Social Security number.
What is it?
Social Security number.
Yeah, yeah. And what else is on there?
Your name.
Your name. Right. And what do you need to do identity theft? You need your name and social security number. So,
Do you also have a Medi-Cal card?
Yes, sir.
let me look at that. So, one of the things that's going to happen this next year, the East Coast and the West Coast are the first to get their new Medicare card. Now, the new Medicare card will still be a white paper card with a red and blue stripe on it, but it will not have your name and social security number on it. So, one thing I'm going to tell you that's very important is that you're going to have to carry both cards with you for about a year. But only when you go to the doctor. You do not keep these in your wallet. You do not keep any of them in your wallet. The only one you need to keep in your wallet is your Medi-Cal card if you have one. And the Medi-Cal card's also changing. The new ones are coming out with the California poppy, beautiful flowers on it. Anybody get one of those yet? Yeah? Okay. So a lot of these things have to do with fraud and helping protect you. But you should not be carrying your Medicare card around with you unless you go to the doctor. Why would you think, and thank you very much, I appreciate that. Why would you think that you might need to have your Medicare card with you?
If you're in an accident.
If you're in an accident, they will take you to any hospital, and by law, they are required to treat you, whether or not you have insurance, what kind it is. They don't care if you got your card with you. You're half conscious, your legs are broken or whatever. And they will find out later. If you have your Medi-Cal card with you or your retiree program card with you, they will link back to Medicare in the system in a New York minute. This is the 21st century. So you should not be carrying your Medicare card unless you're actually going to a new doctor or going to the doctor or some other provider, physical therapy or whatever.
Excuse me.
Another question, yes?
On the Kaiser card, doesn't it have some kind of information regarding your Medicare?
No.
No? Okay.
The Health Nets and Aetna cards and the Kaiser cards and all those cards, they are all smart enough to have a member ID number. Now they do have your name, but it has, and also the VA, by the way, a couple of years ago finally got their act together, and they took the Social Security off the VA card, and they also have a member number now. Okay, Stephen, you have a comment?
Yeah, I wonder if you might say a few words about another distinction, that between managed care and fee-for-service.
Yeah, thank you. Thank you very much. I forgot to talk in more detail about that. So, if you have Medicare and some of the secondary insurance, your Medicare will pay first, your Medi-Cal or your retiree plan will pay second, unless you have a Medicare Advantage plan. Those, as I said, in Alameda County are HMOs only at this time. The Medicare Advantage plans, what they do is they combine your Medicare and your prescription drug coverage combined into one. And if you have Medi-Cal, that's combined in there as well. So that you no longer can use your Medicare or your prescription plan or your Medi-Cal. You can only use that Medicare Advantage plan. That's called, it takes everything, and you have to use them. Now what Steve's referred to as fee-for-service is the other way. When you have Medicare without a Medicare Advantage plan, you have Medicare and Medi-Cal as secondary, and maybe a prescription drug plan also. And Steve may address that more in a while. He's going to talk to you as well. So that's how Medicare Advantage plans work. Now, sometimes people really like them because sometimes you'll get a few extra services. You might get a little vision coverage or a little dental coverage or some other little things. You might get a membership to the gym or some other things. But that's changing also because some of the other supplementary things are also, which never did add those, are now beginning to add those. Yes, another question in the back.
Just want to add as a lifelong employee for county that even though we're talking about Alameda Alliance or the Medi-Cal Advantage being mostly HMOs, all of you know the experience of trying to find anybody that takes Medicare or Medi-Cal. So you can run around and be your own advocate and try to manage your own health care and all your needs through all the individual Medicare plans. But really, for people with disabilities, I can have as a lifetime nurse working in county my whole life. It's really one of the best things you can do is just open up a one-stop shop, have all of your medical records under one umbrella, one set of providers that know who you are. That's the big advantage of doing HMOs within.
That is one of the advantages. Absolutely. However, for some people who are disabled and they want to see specialists in Ohio for their particular condition, then going fee-for-service, Medicare, and some other secondary can be more helpful for that. It really depends, but one of the things that, I'm sorry, go ahead.
You really, really, really do have to have to know how to
Okay, so she's right. What she's saying, if you, whatever way you're going to go, and I think I'm going to clear this up right now, whichever way you're going to go, okay, HICAP can be your advocate. What we can do is we can compare all of the Medicare Advantage plans against the fee-for-service, all of the ones that are available. Show them to you. Tell you what the advantages are, what the disadvantages might be, and help you determine whether the best thing for you is to have one of those Medicare Advantage plans. And she's absolutely right. One of the biggest benefits is having everything under one umbrella. And we have, right now we have 6 or 7. And by the way, those of you who have full Medi-Cal, and Medicare as primary and full Medi-Cal as secondary, there is a Medicare Advantage plan that you could have that has 0 monthly premium and 0 copays for everything. If you have full Medi-Cal. If you're willing to go to Kaiser.
Okay, listen, if anybody wants to ask a question, raise your hand and I can bring the mic. Otherwise, we can't hear everybody.
There's one back there. Question back there.
Where?
For any people that have mobile cell phone devices, is there a way you can get my Medicare.gov website on their mobile phone?
Absolutely, yes. Once you sign up for a MyMedicare.gov account, you can access it from any device. Good question, thank you. I love being in the 21st century.
You need the mic back here for Darren,
I work at the lighthouse. Well, I work in San Leandro, but I work for the lighthouse, which is in San Francisco. But Lighthouse Industries is kind of a satellite for the lighthouse. I have Kaiser insurance from the lighthouse, plus I have Medicare, and it seems that every time I go, I have no co-pays, and I don't have to pay for drugs. Would that change next year, or?
What happens next year to you? You mean what I said about the plans changing every year?
Yeah.
Okay, your Kaiser evidently is from your employer. So usually every year your employer will make some few changes to your plan. So that will have nothing to do with Medicare, depending on what type of plan it is with your employer. Does they pay for and put you in the Medicare Kaiser, or do they have their own contract with Kaiser? So that's what I mean by you need to know the type, and if you call us to make an appointment, we'll help you figure that out. Yes, another
Okay.
question over here.
Okay.
Go ahead. You on the mic?
I'm getting to you.
I ain't got.
He's coming. He's coming.
You were talking about the dental plan. Where's the best dental plan to look up for or what medical will help with us with our dentures? So
you're talking about dental. This lady's asking about dental care. If you have full Medi-Cal in Alameda County now, they have just reinstituted almost full benefits with Denti-Cal. So if you have Medi-Cal fully with no share of cost, then you now also have dental benefits.
we have share cost.
If you have a share of cost,
No, well,
I'm glad to hear you ask that. If you have a share of cost with your Medi-Cal, not other costs that you have to pay for Medicare and all that. If you have Medi-Cal with a share of cost, there may be ways to reduce the share of cost or eliminate the share of cost. And if you have Medicare and Medi-Cal with a share of cost, if you call HICAP, we can sit down with you and try and help figure out if that can be reduced or eliminated. There's a question over here, over on the end. This gentleman on the end. With
so
the,
if I have Medicare, let me get this right. So if I have Medicare, Alameda Alliance, and Medicare, that, what did you say? They could tell me what the share of cost? Because I have to pay the share of costs down some, and then I will start getting things free.
yes, as I just said,
Is that
if you have Medi-Cal with a share of cost, there are ways to reduce it or eliminate it. And if it gets eliminated, then you can have other programs that will help pay other costs. So call HICAP and we'll tell you. The gentleman on the end with the red hair, Mr. St. Patty's Day.
all right, all right.
You're right, you're right.
Down here at the end, this way, other way, over there.
Okay.
Here you go. Can you please refresh my memory? Is SilverScript related with Medicare?
Well, yes, no, and maybe. As with everything in Medicare, the Medicare Part D is in drug. One of the companies that has Medicare, that takes care of Medicare Part D, is called SilverScript. There are probably 36 companies in California that cover Medicare Part D. That's why they recommend you come to us. Let us do a comparison for you, and we can figure out which one will cover your drugs at the least cost. But SilverScript also covers drugs through employer plans, and through retiree plans, and through union plans. So the name of the company is really not what's important for us or for anybody else to figure out what you've got. It's what type it is. And your card will usually say, if it's a Medicare prescription drug plan, there'll be a little symbol on the card that says Medicare with the RX usually on it. Does that answer your question? Okay, good. Do that, please. This gentleman here on the end has a question. Right here. Right here.
Me?
Right here.
Yeah, okay.
Hold on. Give him, the mic's coming to you. Right him. Yeah. Give him the mic.
Yeah, my question is, I wanted to make sure I understood you. Now you say once we get the new card, the new Medicare card, whoops, we lost
The mic, the battery.
His mic went out. Can you fix his mic?
Once we get the new Medicare
Yes.
card, we said we take this old one and keep it away, not with us.
What you need to do is when you get your new Medicare card, you need to carry both cards with you for at least a year when you go to the doctor only. Both cards should be left at home otherwise.
Oh, okay.
Thank you for asking and clarifying that.
And then after the next year?
After the next year, your doctors and x-ray people and every pharmacies and everybody else will be required to only use the new number. They will no longer be able to use their old number. There's another question way back in the middle of that table. Yeah, go ahead, right back there. Here's a question right here.
I can't get over there.
Here.
Because the mic.
Is it working? No. Go ahead, you ask your question and I'll repeat it.
Okay.
Is it possible?
Hold on a second. We're going to let this other lady go first.
Okay.
Is that working yet?
I don't know the details, but I heard somewhere that the high cap will cover if you have diabetes and you need special shoes. Is that true or not?
Okay, high cap doesn't cover any of that stuff. What high cap will do is tell you how it's covered, how you can get it covered or not, or who will cover it for you depending on your insurance. And yes, Medicare does cover durable medical equipment. And it's a little tricky right now because the Bay Area is in a new project area where there are new rules for durable medical equipment like shoes, canes, shots for your equipment for diabetes, all of those things. So yes, if you call us and make an appointment, we can look at your insurance, see if it's covered, or tell you how you might be able to get it covered. And by the way, you see those things on the television, oh, if you have Medicare, you can have a knee brace or we can give you a wheelchair. Be extremely wary of those companies. Do not give them your Medicare number. And if you really want those kinds of things, you can come to a Medicare advocate or call Medicare or call High Cap, and we can tell you if you are eligible for those things. There's a question over here with this gentleman. Kiss me, I'm Irish. No.
Which way?
I can't wait to get.
Raise your hand.
She's got another question.
I see.
Hold your hand in, yeah.
Oh, put a person have 3 medical cards.
Good.
Called.
Yeah, hold the mic, hold the mic.
Me.
He give you the mic.
Give her the mic. Give it to her. Give it to her.
Hold the mic.
But is it okay for a human being to have 3 medical cards? That means be covered by 2 Kaiser and 1. What's the other one?
Well, you know what? I can answer.
And Medi-Cal.
I can give you the answer to that. Anyone, if they are eligible legally, can have 2, 3, 6 medical insurance cards. And depending on what they are, one of them will pay first, another one might pay second, another one might pay third, another one might pay fourth. So, you have to know what type they are and what things are covered and which secondary and tertiary third and fourth cards will cover what Medicare doesn't. The lady with the green shirt, yes, what's your question? Go ahead, ma'am, I'll repeat your question.
I have one of green shirt.
Go ahead, lady, you with the green shirt, green sweatshirt.
Can I get the phone number?
I'll say the phone numbers again. Thank you for asking. I'm glad you reminded me. Okay, tell me when. Well, I'm going to give you 2 names and 2 different phone numbers. For the Medicare and health insurance, it's called HICAP, H-I-C-A, P as in Paul. And the phone number is 510-839-0393. If you want the legal services, that's under Legal Assistance for Seniors. That phone number is 510-832-3040. And we'll be able to get you those phone numbers over and over again. Right behind you, somebody needs the mic. Right there, right there, right there.
That website again that you gave the check.
Benefits, okay, great. This is a great website. It is called benefitscheckup.org. And what it does, it asks you a lot of questions about yourself. And if you put in all your information and you say yes, you are interested in all of the things they list, at the end, they will print out a list of programs that you might qualify for. And the really good thing about this is there'll be a link that if you click on it, you can print out the application for the program.
Wow.
Yep, I'm going to say it again. Benefitscheckup.org. I'm going to say the letters one at a time. B as in boy. E. N as in Nancy. E. F as in Frank. I. T as in Tom. S as in Sally. C as in cat. H as in Harry. E as in elephant. C as in cat. K as in Kelly. .org. Kelly for St. Patty's Day. And it's a wonderful website. It's the National Council on Aging keeps it together, and it can really help. Here's a question here. Yes, ma'am.
No, isn't it checkup though?
No, it's benefits with a S, plural, checkup.org.
No.
Now, what have I forgotten? What do you need to hear about? Anything else about the Medicare and the legal services?
I
Sarah?
want to stop coming to my house. This is Belinda talking. It's a paper. I'm like, my auntie, I could understand her getting for a retiree because she's about to 71 Monday. And I'm watching her mail come in to my house, right? So why am I starting to get what she got and I'm not even her age?
It depends.
I'm 56 and she's 71.
There are so many different programs, and you qualify for different programs at different ages. So it might be one program and not the other, or that could switch, and it depends on your income and assets for certain programs. If you're looking for your stuff,
I'll check into that. I got anything. I just go to the side for now.
So, are there other questions?
Getting out of here.
She's got another question right here. Yes.
Do you help us with this? One time someone changed my insurance, signed and had to sign my name and did it. Do you help us with seeing, would you be willing to talk with me about that?
Oh, absolutely. That's a fraud. If you did not want to change it and it happened, we can help you figure out what happened, get it changed, fixed, or whatever. Probably. And now I'm saying probably because nothing is ever a given. So you certainly, if you call us, we'll be able to take the information and help you with that. Okay, I know we're a little ahead of time, but... Oh, Jan has another question. Go ahead, Jan.
Are they on the piano?
So, you mentioned to me when we were on the email that you had some Braille materials that wouldn't be here in time, but could you tell us what they are, and are they copies of any of the materials that you brought today, or are they different?
Yes, no, some of them, Medicare has some Braille materials. And when I get them, I will let you know what they are. And we can give you some to hand out if you like, Jan.
Okay.
And some of them are, some of the materials that I have here today are not in Braille.
Live.
Yeah, that is a good question.
They really should be in Braille.
Absolutely.
And so maybe there's some way we could talk about that and see what we need to do to get those done, because they should be large print in Braille, everything that you have.
Absolutely, and these are the things that come from Medicare. So the only way to get them in Braille and to get more large print is to talk to your local public servant. Do you know who I'm referring to when I say your local public servant? Your senator, your legislator, the people who work for you, who you elected.
I'd like to know if most of the material that you brought today is on your website, because that would be an interim solution for some of us.
Thank you very much. A lot of it is on the website. If there's something that you're interested in and you don't find it on the website, please call us and we can either email you a link or tell you where to go to get it. Yep. Steve, what are you going to be talking about?
Well, I'm talking about, I guess, some of the things you talked about. I'm going to point out, for example, that unfortunately, durable medical equipment does not cover most of the things that blind and low vision people need.
Well, there are programs around. But Steve, hold off on that.
Yeah, there's a question, actually. I was going to ask if it always worries me. You might want to talk about it and make sure that everyone knows that Medicare does not cover long-term care.
Medicare does not cover long-term care. However, there are ways to get it. I'm glad you brought that up, Steve, because there are ways to get coverage, and we have counselors who specialize in long-term care and ways that they can tell you about getting long-term care, and mostly the long-term care would be covered under Medi-Cal, not Medicare. Thank you, Steve. And I think I'm pretty much done, so if Steve wants to come up and get started, we can do that.
What about that blue book you were talking about?
The red book. Call your disability organization and ask them about the red book.
Oh, excuse me. Which one of these booklets that have, the different information that you went over? I don't know which one is the
Well, I have one here in large print. That's No, I know you've got a lot to do. A 2 to 3 minute break, and then I believe that we will be introducing Steve, who we all know by his first name now. And those are the only large things I have.
Then we gotta go fast. How are you doing, Kelly?
Good. I think I'm just
You've
gonna
been
keep this.
standing.
Well, I've been sitting, standing.
All right.
So there's a chair like that, right? So
This is the podium.
yeah. And it's
just
still
pulled out of the way?
it's still running. So I'm gonna
right.
leave it running.
Good on you, girl.
Yeah.
Wow,
Of the diabetes.
bless your heart. That was wonderful.
Yeah.
Diana.
Yes.
Wonderful. I just want to thank you for your extraordinary command at the microphone. It's wonderful.
I'm really loud.
You've
Hold
been,
on 1 second.
you've been to this rodeo before.
Yeah, here's the other one. Debbie, that's Medicare and you and all the Medicare.
Wow, that's huge.
But you know what? Yes, I have
That one I would want too. The CD. Thank you. Thank you.
Oh, I just see that.
Glowing. Oh my God.
Okay, all right, good.
I'm trying to bring into the spirit.
But you're more. But no, but seriously, she was.
Good. Oh, I'm sure she is.
We need this kind of infusion into the center. We need it. Yeah. Oh, I'm excited. I'm excited.
The mic is on.
You have it? All right, we've taken our little break, and maybe some people have gone out, but I want to say, before we start with Steve, I want to thank everybody for coming, and I want to tell you that last week we had a representative of the San Francisco Foundation come here. He was very impressed with our center. And I want to thank Jen and Doyle and Dorothy.
Where's my chair?
Jen, and I don't know if Catherine's here or not, but a number of people for speaking so articulately and representing us so ably. And I want to thank every one of you for coming to this workshop. And I'd like to hear from you so that we can get other grants to support additional workshops. For instance, we're thinking of having one for families of visually impaired people. Okay, we're going to start. And I would like it's my pleasure to introduce Steve Mendelson, who is an attorney, and he's an author. And years ago, in the 80s and 90s, he wrote some groundbreaking books on financing adaptive technology, if you don't have the money for it, and tax options for blind people. And he has led the way in urging reforms on Social Security and other provisions and assistance that disabled folks, especially blind people, get. Steve was very active on the National Council on Disability, which is a federal, finance organization. And it's my pleasure now to introduce Steve to talk about accessibility of, I guess you'd say, the medical establishment. Steve? Steve?
What?
He wasn't up there.
Good afternoon, everybody, and thank you for the opportunity of speaking to you. I'm very excited to be here today for two reasons. First of all, because we have what I hope will be some valuable information to discuss. But second of all, because I sense a real energy and dynamism here. I have the distinct feeling that the East Bay Center is on an upward trajectory. I'm very proud to be here to witness that and to contribute to it whatever way I can. So we're going to be talking about accessibility in healthcare or civil rights. Accessibility in healthcare, civil rights in healthcare, or non-discrimination in healthcare. You can use almost any of those terms. But that does raise a question. What do we mean? Definitionally, what does it mean to say What, is that not working?
Now,
Okay, I just have to get close enough for it to work, but not too close to overload. Okay, so you can use any of those terms, and it's sort of appropriate to use different terms because we're really talking about a very amorphous area. So what do we mean to say when we have a right to accessible health care and to equal treatment in health care and to non-discrimination in health care? Well, it means different things in different contexts. Diane has already told us that we have different kinds of rights under different kinds of insurance and under different benefit systems. So the question in all of those is always initially, what does anyone who has this kind of insurance or this kind of benefit is such a person entitled to? And what distinctions, if any, are being made based on disability? If I go to a doctor's office and everybody who walks into the office gets punched in the face, then I can't very well claim that it's discrimination against me as a blind person. If the only person who gets punched in the face is me, then I probably can. So the first question we always have to ask ourselves is, what are we entitled to as part of the broad class of people who have the service or have the benefit or have the insurance, and what are we entitled to or what are we being denied by reasons specifically of disability? And again, that's not always easy to know. As I say, you run into a nasty person. If they're nasty to everybody, it's not discrimination. If they, but if they're nasty to me particularly or distinctively or especially, then it may be. These are subtle things. Most cases of discrimination end up being what are called fact-based cases. It's easy if I go to a doctor's office and they say, I'm not going to treat you. You have a disability. You're blind. Go away. That's an easy case. And the Supreme Court decided only 5 years after the ADA was enacted that was illegal. But what if they say, I can't treat you because I'm a foot doctor and you're here for psychiatry? What happens then? Is that discrimination? Well, no. But what if the doctor's office, who is the foot doctor, is in the same complex as the psychiatrist's office, but I can't find the psychiatrist's office, and they won't help me to find it. They won't tell me where it is. And they say, get lost. Is that discrimination? Well, maybe the answer depends on whether I end up getting the care I need, and maybe the answer depends on something else. So from that standpoint, let's talk, especially today, as we've been asked to, about accessibility. What does accessibility mean? Accessibility means, to my mind, are we getting the services and information in terms of equality to other people, and on terms that are adequate to satisfy our rights, not as people with disabilities, but as healthcare consumers. And what does equality mean? Well, to my mind, equality means three things. It means accurate, timely, and appropriate to the circumstances. Well, accurate means if people are getting copies of their tests, can I get access to the copies or the content of my tests? It means, what does timeliness mean? It means if everybody else gets their test results back in 3 days, can I get mine in 3 days? And what does appropriateness mean? If everybody else gets their test results and confidential, but I get mine screamed out to me by a nurse across an office, what does that mean? So the question always comes down to one, to my mind, of these three. These three criteria, they're not used in a standard way in law. The law doesn't really have standard ways of addressing these situations. I'll tell you some of the ADA terminology, which is used to address them in a moment. But these are the three criteria that were set out in a very interesting series of cases in the education law context a couple of decades ago, which I think are still the best three standards, the best three touchstones ever developed. And I try to apply them to accessibility of medical services, and for that matter, of any other kind of services, healthcare services, anything, as possible. So what are we worried about in a medical setting today? First of all, we're worried about access to the various forms that we have to fill out. You can't go for any kind of medical services these days without filling out a lot of forms, a lot of questionnaires, health histories, all kinds of things, waiver forms, consent forms, you name it. Every kind of thing that you want to do has a form attached to it. Well, I have a right, as a medical consumer, to know what those forms say. But if they're not accessible, that is, if they're not provided in a format that I can read, braille, large print, online, whatever the case may be, if they're not provided in a form that I can read, then are they truly accessible to me? And again, that comes back to what kind of reasonable accommodations or auxiliary aids and services, as the ADA puts it, the medical facility is willing to make. And again, I judge those by the three standards of timeliness, accuracy, and contextual appropriateness. So that's number one. Once we fill out all our forms and we go in to a doctor or lab technician or so forth, and there are going to be a lot of things that they're going to do or ask us to do. There are going to be lab tests. We can't always know, for example, if they are deciding what lab tests to give us based on some crazy notions about disability. I know of a case once where a person was very much in need of a stress test for a possible heart defect. But they decided not to give it to the person because they're afraid the person in walking over to the machine might fall and hurt themselves. Well, that's fine for them. I'm glad they cared about their mythical liability more than the patient's health and life. But the real problem here is the patient, unless they knew that they were in for a stress test, wouldn't know that not getting one was discriminatory. Or there's a possibility that they knew they didn't get one. The facility might well say, well, the reason wasn't discriminatory. The reason was you didn't really need it after all. We decided, or your insurance didn't cover it, or in fact, we had some other reason not to give it to you. We thought your heart was already so weak, if we gave it to you, you'd probably die. So again, it's a question of getting at the real facts. And the facts are very hard to get at. We have the question of testing. We have the question, again, what kinds of questions. Doctors ask us, you know how it's been traditional, a traditional justice of medicine, that when women go in for medical care, they get taken less seriously than men. And they get told very often that it's all in their heads. Well, the same happens with people with disabilities. People with visual disabilities and people with other disabilities. They don't get taken as seriously. They don't get the same attention, the same respect for their subjective account of their life experience that other people do. And again, it's not always easy to know if that's happening, let alone what to do about it, because you assume that the medical professionals you're dealing with have a degree of expertise and are proceeding in a standardized way based on the best practices for the discipline and for the situation. If they're not, you can't know it, and the trouble is they don't know it either, because they are guided in many cases by their fears, their prejudices, their misconceptions, and they're not going to tell you what those are.
Hear, hear.
And you may never know. So what it comes down to is that the consumer with a disability, particularly the blind consumer, who doesn't have the access to the documents, to the forms that other people may do, has to know more than everybody else. Has to know as much as possible.
I'm glad you said that, but
Yeah, has to know as much about possible about what to expect, what is reasonable to expect, and what to demand if you have to demand it. Now, the same is true, for example, with pharmaceuticals. We've made more progress maybe with access to pharmaceutical information than with anything else. And that's because of a concept known as structured negotiation. And many of you may know, and I'm proud to say, because my wife Judy Wilkinson is the president of CCB, that CCB has been involved in this longer and really relatively more successfully than almost anyone else. We've made great progress working through wonderful attorneys like Linda Dardarian and Laney Feingold, and others too, but Linda and Laney foremost, in achieving what are called structured negotiation settlements or agreements with various pharmaceutical companies, whereby they have agreed and accepted on a contractual basis, as it were, not conceding necessarily in all cases the law requires it, but agreeing by contract, in effect, to provide accessible pharmaceutical information about the dosages, the prescription usage, some of the warning labels, things of that nature. So, for example, if you are a member of Kaiser, you get that now, and you can get it at CVS, and you can get it at a number of other pharmacies too. And I presume pretty soon the drug dealers down the street will be selling them as well. So that's very important. And to a very large degree, it is the case that assertion of our rights in the healthcare field will have to proceed for the time being on the basis of these kinds of negotiated agreements with various providers, various insurers, various companies, various medical providers, and so forth. Because it doesn't look like we're going to get much support from the federal government anymore, at least not for the foreseeable future. And the state is limited in what they can do because of the way federal laws take precedence. So it's going to more and more come down to advocacy to us as individuals. And of course, yes, it's very important to talk to our legislators, keep the pressure on in every possible way at federal and state level. And also, by the way, to regulatory bodies as well, because regulatory bodies are as or more important in the actual nuts and bolts of the day-to-day health care that we experience as legislation, as laws are. If I want to understand Medicare or change Medicare, the place I'd go now would be to the federal agency, the Centers for Medicare and Medicaid Services, CMS, that interprets and applies the Medicare law. They're a lot more important right now than Congress is. They move faster, they have more discretion, more of what they do is impactful but low visibility, and they are the place where the real action is taking place. This is, by the way, true generally about our life now. More and more of the real decisions that impact our lives from a legal standpoint, from a regulatory standpoint, from a civil rights standpoint, are being made in administrative agencies and not by legislatures at all, because legislatures grant administrative agencies huge amounts of discretion to interpret the laws and to apply them. And as we now know from the last year of a new administration, the administrative agencies can dramatically change the law, almost turn the law around without benefit of a single word from Congress and without benefit of court decisions. And that's rather frightening, but it's the reality that we live in. Now I want to mention, we were talking before about Medicare. I want to thank Diana for her wonderful presentation and for the wonderful resource that her organization makes available to all of us. A couple things that she didn't have time to say, I'll add, which is number one, that you can get your individual materials from Medicare in Braille. If you contact them, let them know you want your various annual statements and other individualized documents from Medicare in Braille. They will send them to you, and that's an important resource.
Steve, can I tell people an easy way to get a hold of Medicare?
Yes.
The easiest way to get a hold of Medicare is when you call the Medicare number, you will get a menu of options. Do not press any buttons. Do not say any words. The only word you will say after that robot reads all those things, say the word agent.
Oh.
Now what happens is the robot comes back and you will say the word agent again. And on the third go round, you say the word agent and you'll get a person.
Thank you.
Wow.
Thank you. That is true. And by the way, again, that's not only true for Medicare. The big distinction is some places you have to say representative.
Yeah, right. And that's because of disability laws, so that's why they have to do that.
It wasn't as you say, they put you through hoops by making you say it 3 times. But this is a case. This is not a case where 3 strikes you're out. This is a case where 3 strikes you're in. So you can get your individual social. Now, if you work with Kaiser, Kaiser entered into a huge settlement agreement with CCB and a couple of individual litigants a couple of years ago. Again, thanks to the efforts of our wonderful attorneys. And Kaiser provides now a suite of accessibility services. And they even have designated officials who, if you have an accessibility complaint, will respond to it and hopefully deal with it. And in my experience, my wife and I have been Kaiser members under what's called Kaiser Senior Advantage just since January. And although there are a lot of problems with it, that is one thing that they do seem to take very seriously. How seriously they'll take it when the consent decree ends, I don't know. We'll find out.
Steve, I have a question.
Yeah.
Do you know anything? I've just found out recently that Medi-Cal, and I'm wondering if you know anything about this, Medi-Cal has a group of what's called Medi-Cal patient advocates. And if you call their phone number, they will get back to you and help you with your Medi-Cal if you are disabled or you need Braille stuff or whatever.
I haven't had any experience with them, but that's wonderful to know. You know the phone number offhand?
I don't have it with me, but if you call the office, we'll be able to give it to you.
Could be a wonderful resource.
Yep.
I'm very glad to know about it. And for those of us who have or need Medi-Cal, that'll be very helpful. So again, I want to go back to this question of DME, and Diana, you may want to help me out on this. If you do, I'd be grateful. But subject to the changes that have been coming along in such areas as competitive bidding and so forth. The durable medical equipment component of Medicare leaves a lot to be desired so far as blind and low vision people are concerned. They don't cover accessibility devices like braille notes or picture streams, obviously. And worse yet, they don't cover closed circuit TV magnification devices. And they don't even cover eyeglasses or lenses, except in very specific cases having to do with certain kinds of post-surgical or other kind of post-treatment situations, very limited situations. To give you an example of how complex that can get, one of the things they do cover are continuous glucose monitors. Okay, anybody who has diabetes, particularly type 1, but type 2 also in many cases, can benefit from a continuous glucose monitor. Well, Medicare about a year ago approved one company to provide those, and they do. And it is possible for a blind person to learn to take the reading, but it's not possible for a blind person to read the output. But no problem, because some smart people found out they could read the output with their iPhone because there's an app for that sort of thing. But then Medicare came along and said, no, that's not legal. And Medicare is now saying that if we find out that you're getting the output of your continuous glucose monitoring device through the iPhone app, we will take it away. And further than that, they have apparently, I haven't verified this, but I was told just this week, they have instructed the manufacturer, a company called Dexcom, to redesign their devices to make that impossible for Medicare beneficiaries. It's complicated. We don't exactly know yet. I have a theory, but I won't go into it. I can't prove it. But anyway, it's an example of how this question of what is equality, what is discrimination, what is accessibility, of how incredibly complicated it gets. And it gets complicated in another area too, because in theory, Medicare, being a public sector program and involving the dispersal of public funds, to be sure, funds which mostly you've paid in the course of premiums over your lifetime. That's right. But still, they're technically considered public funds, and as such, they should be governed by Section 504 of the Rehabilitation Act. Section 504 is a non-discrimination, broadly based non-discrimination provision on the part of those who utilize, well, on the part of government agencies and on the part of those who utilize public funds. Well, fair enough. But it gets complicated when you have these managed care contracts, like, for example, the managed care contracts that Diana was describing before. Because the managed care providers, and sometimes even the fee-for-service providers, if they're working under contract, say, look, the only thing that governs us is the contract. So if CMS, or where the state is involved, the state wasn't smart enough to include very specific provisions about accessibility in our contract, then we're not obliged to provide it, notwithstanding what they might be obliged to do if they were providing it directly, because we're not being paid for it, and we're only required to do what's required under the contract.
If they're receiving federal funds, they're required.
Say again?
If they're receiving federal funds, they're required.
Yes, in theory. In theory, that's exactly true. And they are receiving federal funds, of course. But their position is that legally speaking, whatever the federal government is required to do, they're only required if the contract specifically specifies that they have to do that. Now, 504 specifies it and should be written into all contracts. But in Medi-Cal, for example, it isn't in all cases. Well, I don't know about Medi-Cal, but in a number of states, it hasn't been written into the contracts, and therefore the providers say they don't have to provide it. And that's been litigated. Or what does it mean? Now, another big, huge area of accessibility that I want to talk about, and I want to spend some time talking about, is growing increasingly important, is the question of online access. And here, healthcare and every other kind of service or every other kind of commerce that's provided online is implicated. So what rights do we have as blind people to accessible online access? The answer is we don't exactly know. The answer is that going back as far back as 1996, the Department of Justice said that all people, including with disabilities, have a right to the same information as people without disabilities. So that, in principle, that's what you call black letter law. It's the headline. That, in principle, is true. But does that mean that everything which is provided online has to be accessible? And if so, in what time frame and to what degree? And who defines accessibility? The Department of Justice, in the waning days of the last presidential administration, well, actually not merely in the waning days, from 2010 until the end, was on the point of issuing regulations specifying exactly what the ADA Title III, which is what's called the Public Accommodations Title, what the ADA Title III and what Section 504 of the Rehab Act, for that matter, required people to do with respect to online accessibility. They never issued those regulations. And so what you're getting now is you're getting a lot of accessibility suits under Title III. Most of them are being settled with these consent decrees, with these settlements. Some have come successfully through in litigation, but in California, because we're in the U.S. Court of Appeals from the Ninth Circuit, the Ninth Circuit has taken a very dim view of any right of accessibility. Why? Not because they don't believe in accessibility, but because they say that websites and online information generated from them or through them are not covered by the ADA at all. Why? Because the ADA applies to, quote, places, unquote, of public accommodation. And they say that a website is not a place. You don't go there. You don't hang out there. You don't meet your friends there. You don't go buy a drink there. It's not a place. But this is a silly and arcane definition, especially when you consider that the ADA was enacted before web accessibility was even a gleam in Steve Jobs' eye. But nevertheless, courts are terribly divided on that right now. Some circuits say, of course, use a little common sense. It's not a physical location, but it is a location in any meaningful sense. It's where business gets done. And other courts and other circuits are saying no. So we don't know yet, and the Justice Department is not going to issue any regulations to clarify the matter now. You also get defendants now who are arguing, well, we'd like to do it, but since we don't have regulations, we don't know how to do it, we don't know what's required of us. I'm afraid if we do the wrong thing, somebody will sue us for doing the wrong thing, so we're going to wait for the regulations. And they whisper, which we know will never come. But they whisper that. So this is a big problem. So again, we're lucky we have some limited possibilities under California law in the sense that we can proceed under the UNRU Act. And California law has the advantage that under California law, you can get damages. Not huge damages, but some damages, which you can't really get under the ADA, except in very rare cases. And that's pretty exciting. But it's not that simple. Because we don't even know for sure if the ADA applies. Why not? Because there is something which you all know well called the Affordable Care Act, otherwise known as Obamacare. And many people think that anything that Obamacare deals with, it preempts. That is, that anything which it covers is not covered by other states. A good example of that, a comparison would be, you've all heard of the Air Carrier Access Act. Well, the Air Carrier Access Act defines our civil rights in air travel, and it preempts the ADA. The ADA does not apply to air travel. So that if that nurse turns out to be an airline pilot later on and punches you in the face again and says I'm doing it because of disability, your only rights, and believe me they're limited, are under the Air Carrier Access Act, not under the ADA. So we don't even know for sure the extent to which the ADA covers access to medical information or whether the Affordable Care would cover it, if anything does. And if it does, then that would be covered under a section of the Affordable Care Act called Section 1557, which is the non-discrimination and civil rights and equality provision of that law. But of course, the regulations on that have never been very clear. There's very little case law, and any day now, CMS may decide not to enforce it, which they haven't done much of anyway. The related problem, of course, there are other provisions of the Affordable Care Act regarding what insurance has to include. And there are 10 categories of coverage, and one is equipment. Well, that should help us. Some of us need equipment. We need closed circuit TV monitors, we need braille notes, we need Victor streams, things of that nature. But again, no one has ever definitively interpreted what that means. It just hangs out there. Now, let's talk a little bit about insurance itself. Because unless you're rich, or unless you're able to get some charity care, you're not going to get much medical care at all, discriminatory or non-discriminatory, either way, without health insurance. So where does accessibility come into play in the area of health insurance? Where does civil rights come into the area of health insurance? Again, if you're in a managed care program like Kaiser, or if you're on Medicare or Medi-Cal for that matter, depending which level of Medi-Cal you're at, nobody can discriminate against any individual. They can't say, well, Medicare Part B, the monthly premium is $134, but because you're blind, we're going to make your monthly premium $144 because you might cause us more money. You might fall down on the way to the hospital or something. So, but they can't do that. So that's all right. And they can't even deny you coverage on an individual basis if you meet the overall eligibility criteria. Medicare, for example, you're 65 years old, you've paid in, you're willing to pay the premiums, and so on and so forth, or employer-sponsored health insurance. You're properly employed, you meet the employer's definition of who's eligible to participate in the plan, and you're willing to pay your employee's share. So they're not discriminated. But when it comes to individually purchased insurance, which those of us, for example, who are self-employed often have to do, or people who are unemployed who don't qualify for Medi-Cal and who, for some reason, have to buy private insurance. When it comes to that, the problem is it's not so clear. Even with insurance bought through the exchanges, through the Affordable Care Act exchanges, they can't discriminate against you as an individual, but they can create group categories of benefits, packages or policies, which we know have the subtle effect of discriminating without saying so. For example, one of the ways they do this is with drug tiering. In a drug plan, drugs will be put into different tiers depending on their cost or expensiveness. And there have been a couple of lawsuits about insurance companies who have put all HIV drugs, even cheap ones, into the highest cost tier with the highest deductibles and the highest copays to discourage people from using them and save themselves money from having to pay for them. And they do this with other conditions too. So you get discrimination going on that way, but it's subtle and it's hard to prove. And a few courts have said that it's actionable, meaning you can do something about it. And a few courts have said it's not, or have said, well, you haven't really proved that they had discriminatory intention, et cetera, et cetera. A lot of things of that nature. So again, we just don't know. So this is a dynamic and exploding area. I would say in all cases, it's very important to be able to articulate not merely what your rights are, but what harm accrues to you as a result of being denied your rights. Now, there's not enough for me to say, well, you've denied me access to my information on the web, and I need to know my test results. What you need to be able to say is, by not knowing my test results, my health and life will put at risk. After all, you tested me for bubonic plague. I'd like to know if I have it, So this is very important to understand what it is you're actually contesting, what it is you're actually arguing about, what is the harm which is being done. It's always important to focus on the harm that's being done. It's also very important to think about how you complain and who you complain to. As I say, going to court is one option ultimately. That usually takes a lawyer. It's usually expensive. It's usually time-consuming. And very frankly, nowadays, most defendants find litigating in terms of it's cheaper than complying. They really do. And this is the trouble with all our civil rights law. There are so many ways that you, as a defendant, particularly you have deep pockets, can drag out litigation indefinitely. You can exhaust litigants. You can exhaust their children. You can exhaust their grandchildren. And the way that the civil rights community, disability and otherwise, has dealt with that is through what are called class actions, getting large numbers of people who have faced the same kind of injustice together to sue as a group and thereby both share the costs and also make the recovery larger if there is a recovery at the end. But the Supreme Court doesn't like class actions, particularly consumer class actions. Doesn't like them at all. It's been making them more and more difficult to file. And the day is probably coming close, especially with the new composition of the Supreme Court and with likely further changes over the next couple of years, when class actions of the kind that we are used to in civil rights are going to become impossible to maintain. And that's a very serious matter. We're going to have to deal with that, I think, by emphasizing state legislation. We're not going to get very far with Congress as it's currently constituted. And even after November, if the Congress, makeup of Congress were to change, you still have the problem of presidential veto to worry about. So I think we have to work on state legislation. And there are opportunities here. For example, right now, there are a couple of bills pending in Congress there, which have some medical implications, but some general accessibility implications, which apply to healthcare and to everything else. There's one bill, for example, to establish a state office of accessible technology, which would oversee the laws which already exist, which require state agencies to make their technology accessible. They make the information their technology provides accessible. These laws already exist in the state, but they're largely unenforced, they're not understood, and there is no real mechanism for evaluating on an ongoing basis whether or not they're working, how well they're working, how well the people who are supposed to apply them understand them, or what can be done if they're not being implemented fairly. This legislation would go some way to resolving that. That's a good bill, so we should all support it. Pardon me. There are a number of other bills that we should also support too, but I'm not really here to lobby. I'm here to try to just tell you to be alert to these possibilities, and never to overlook the potential, the power that you have as individuals, advocates. Remember, in this day and age, whatever is wrong with social media, the one thing that's good about social media is that it makes everybody a publisher. Mm-hmm. And everybody can start a movement, and anybody can start a petition, anybody can start wildfire, and it's tremendous how much energy and attention a good idea can generate in a short period of time. Of course, the trouble is bad ideas generate more, but never mind that. Good ideas can generate their share too. So with insurance, in the cases where there are individualized decisions being made, or decisions that, though on their face are not individualized, are actually clearly based on distinctions based on disability, there's usually nothing you can do, because under the ADA, the law says you can only sue an insurance company, apart from denial of public accommodations if it won't let you in the door of their office, or has an inaccessible staircase or something that people in wheelchairs can't climb, things of that nature. But so far as the actual selling and administering of insurance, you can only sue them if you can prove that what they did is in violation of the law of the state where you're trying to sue them, where you live. And that's very difficult to do. But at some point, we're going to have to look very carefully at California's insurance laws. Not easy to do, because the insurance industry is extremely powerful, as we know from efforts to exercise a little more public oversight of it in the past couple of years have demonstrated. The failure of those efforts is demonstrated. So nevertheless, we're going to have to be looking as a community at what our state insurance laws are, and figure out if we can lawfully and effectively adopt laws which would allow us to meet the federal standard of violation of state law, that would allow us to take actions to sue insurance companies for discrimination. And hopefully that will come. But just remember this for the time being. If an insurance company says that they are refusing to insure you or are charging you a higher premium because of underwriting considerations, you certainly have a right to ask them, what underwriting considerations, what actuarial considerations are they using? What studies have they done? What actuarial studies have they done to prove that blind people are inherently more risky than non-blind people? Or to prove that people who were blinded at the age of 2 in car accidents are at the age of 75 a higher risk than somebody else? And the answer is they don't have any. They don't have any at all. They would never bother to do it. It would be too expensive for them to do it. They just say it. And what the courts have not yet told us is whether or not just saying it is enough to shield them, or whether they can be put to the proof of having to show it. And we don't know. We just don't know. It's going to take more advocacy, more of you, more of us, more of everybody to find out and keep waging the battle. I'm going to stop now and take questions. I'm sure there are many, many other areas that we haven't covered yet that some of you would like to cover. And I'll try to if I can, with Diana's help I can. And we'll see what we can do here. So let's stop for some questions from you.
Okay, I got one right here.
Thank you, Mike. Where's the microphone?
Thank you. Hi, Steve. This is Ray.
Hey,
I have 2 questions. Earlier, you mentioned something. I'm not sure if you mentioned 10 qualifications or 10 questions. What would that be under? You mentioned something about the number 10.
Yeah, I mentioned that under the Affordable Care Act, there are 10 categories of healthcare services that insurance policies that are eligible to be sold under the exchanges have to cover. Whether it was surgery, nursing home care, post-operative, outpatient, and one of them is equipment. But nobody knows what equipment means because nobody's defined it. That's what that 10 referred to.
Okay. And my second question is, how many people does it take to start a class action suit?
1. And the way you do it is this. Every class has to have what's called a class representative. Somebody who is the lead plaintiff who represents the class. So if you go to a good lawyer and have an issue that applies to a lot of people, what that lawyer will help you do is go out and find other people to join the class. They can't advertise for clients, but there are ways to publicize the existence of the lawsuit and to find out people who are appropriate to join it. They have to be people who have the exact same situation. And as I said, the courts have been narrowing what the exact same situation means. But nevertheless, it's still possible to some extent. And so that's what you would do. And then you, Ray, will become the lead plaintiff. And when the damages are awarded, you'll get the biggest amount.
Thank you.
Any other question?
How do they pass the word?
How do we pass the word?
Well, for example, in CCB, we often let our people know when something is pending, if they want more information, or if they think it might be pertinent to their situations, to get in touch with the lawyers in question or somebody else. That's one way to do it. You know, in any networking situation, in any community grapevine type situation, you know, like any other good gossip, it gets out.
Okay.
Hello, this is Claudia. I have a question in regards to accessible labeling of prescription drugs. If I were to walk into my CVS local store, could I get that at my local store?
Well, you should be able to. There's often a lot of slippage, but in theory, yes, and certainly from their mail order. What they'll give you typically is what's called a script talker. So it will actually basically read the information. Now, some pharmacies' mail orders will give you Braille, some won't. I don't know right now about large print, but in theory, when you go into CVS, they should do it. If they don't do it, call me up. We'll figure out what to do.
What's your number?
Now, I have to tell you, I'm actually, I don't practice law anymore. I'm retired, and my professional motto is I charge no fee and you get what you pay for. But I'll find somebody who can help you.
Anybody else?
I heard a few things, you know, on my hearing aids, just saying it out, okay? That's why I talk real loud, all right?
It's okay, go ahead.
Stealing identity.
Identity theft.
Now, you know what? I was, not to say I'm going out of my mind, but the police told me I had to go see a shrink. Because I keep telling him that somebody keep following me everywhere I go. I can't see them, but I can sense the action. You know how you can feel somebody there behind you breathing down there. You know how they can wait and then, because I did this too. I let my son, the one that dropped me off. I said, watch this. We got out the car at the bank. I said, just watch this. We can go in there and people gonna come right back out. Why did we go in the bank? Because, you know, they bug us in. So we get in the bank, and then I just like wait a pause for me, you know, put a little foot on, and turned around, went out the door.
Okay.
And there was a party coming in the door. I thought it could be anybody.
Okay,
But you know, me, myself, and I check for cars, truck, they follow me here.
Okay, what you
I
need
told
to
the
do-
police that I have on my
what you need to
camera. They don't believe. Because
all I can say is what I would do. And what I would do is get somebody, obviously or unfortunately necessarily a sighted person, with a camera to watch and take a picture. And if you see the same person behind you twice, that's them.
It's kind of hard because if you look at, say right there is my house, right? This is the street right there, right?
I don't know what else to suggest,
Now, look
unfortunately.
at the house, the sidewalk, the street. From my house to across the street, over there, where that little light going, I see light in there right there. It's a gate. It's open, and you can look all the way over to International. While the car is sitting right there, watching my house, My mother and my great auntie were driving the car, and they said, I saw such and such sitting in the car over here.
Okay, again, get somebody, take
I
a
have a
picture.
camera on my
It's
house.
the same license plate, it's the same license plate. It's there every day.
But okay, and that
Or,
part.
you know, when you're
Okay,
home and not when you're not home.
That's a
or-
part of me identifying, a notice is somebody trying to, okay, follow me to
You gotta get,
CPS.
you gotta get evidence.
If I'm
You
good
gotta-
on my
yeah.
medication, I'm looking at.
I don't know what else to
You
suggest
know,
right
I'm
now.
getting kind of.
Question for this time period, I don't think we can answer that here, Melinda. We might be able to talk about it later and come up with some kind of thoughts about it, but I don't think we can do it in this session.
Well, the police already thought and think I'm crazy. So I told her I already had went to the doctor. I told her. Okay, so that part.
So we have other questions?
There was another question. Okay, that, they sit there, and, yeah, come back to me, and I'll give you one. Okay, I'm just so anxious to say what I have to say.
Any more questions?
Oh, yeah, your phone number.
That's it.
My
You say you
phone?
retired, right?
Yeah, I'm retired. I'll give my phone number anybody. It's 510-357-1844.
I've been doing it for little advice.
Of course, I also have to tell you I sleep most of the time.
Where is my hearing aid go?
Any more questions?
You have to shout, the mic isn't working again.
Speaking of hearing aids.
Yeah.
Are they considered durable
There you
materials?
What is it?
Under Medicare,
Yeah.
I believe, and Diana, help me on this, I believe, unfortunately, by and large, not.
That's correct. They're not under Medicare. However, if you have a Medicare Advantage plan, it may be.
That's
Also, if you have VA benefits, they will probably be. And there are other kinds of insurances that work alongside or with Medicare that may cover it, but Medicare itself does not.
But as you say, if you get the right Medicare Advantage plan, the key thing about Medicare is this: when you get Medicare, Medicare pays. They don't pay the whole cost of things. They pay 80% of what they consider to be the reasonable cost. They have what's called the cost schedule. And the reason you want to supplement, whether it be managed care or otherwise, is to pay the other 20%. But remember also that most, I won't say most, but many managed care plans will pay the other 20%, but only the other 20% of things that Medicare covers. So there's something that you got that Medicare doesn't cover at all. Many of the managed care plans won't pay for it either, but there's some that do. And hearing aids would be a good example of that for the plans that do.
Well, Medicare, you pay for a hearing aid, a whole hearing aid.
Yes.
Okay,
So-
in the ear.
Well,
Okay, the mic isn't working, so.
Hearing aid, Kaiser, I'm on managed care,
right.
and I paid $240, I think, for some hearing aids about 4 years ago. And I would go in and have them checked from time to time, and then the audiologist warned me that my what do you call it, warranty would be up by a certain time. So that warranty, I was just in there at the right time, as it turned out. And so I get free care otherwise, until I buy the other hearing aid.
Now that's also an interesting point. Some of the managed care plans, which do cover things that straight Medicare doesn't, like hearing aids, some of them will have provisions like they'll only cover them every 4 years, or they'll cover new batteries but not repairs, or they'll cover repairs unless they're caused by the negligence of the user, or this and that. So there can be all kinds of, I would say fine print, let's say fine braille. There'll be all kinds of fine braille distinctions here. And this is true, even more so under Medicaid, or as in the state Medi-Cal. There'll be in most states restrictions for DME, how often it can be replaced, what repairs, if any, will be covered, what components will be covered. There's one case that I came across years ago where the state Medicaid program, not Medi-Cal, a different state Medicaid program agreed to pay for the power wheelchair, but not the seat cushion.
Yeah. By the way, HICAP can help with some kinds of appeals when you're denied certain things that are supposed to be covered under certain types of Medi-Cal or Medicare, the high cap program can help you with appealing that decision and try and getting it reversed, like the cushion for the wheelchair or whatever.
That's very important because don't assume that the denial is correct.
Yeah.
The denial is a knee-jerk reaction. Their position is, well, we'll deny them. If we're wrong, we'll lose on appeal. So what? Or maybe they'll die first. We won't have to pay. Even better. So don't assume just because they say no that they're either sincere or have any idea what they're doing.
That's correct. Absolutely.
Can I ask the high cap lady?
Yes, there's a question here.
I wanted to know, when you, an insurance person, hold on,
You need a mic.
an insurance person sold me my managed care plan.
Yeah, and I wondered, did they, when you have it, did they take your Medicare and did she get some of it?
No, that's a really good question. She's asking about going to insurance agents and brokers to get insurance for Medicare, managed care, or other types. Be very careful. They get paid not by Medicare, but by you, in a sense that if you're paying premiums for any Medicare, they may get a piece of that or maybe not. So there's lots of different kinds of arrangements. But Medicare does not pay brokers or insurance agents for anything they sell you.
Wow.
But
Any other questions? We got
don't
a mic
forget,
again.
HICAP can help you look at all of those plans and figure out which one might be best. It's not just brokers or agents that can do that for you, and HICAP is mandated to be unbiased.
And by the way, the same is true with financial planning. If somebody gets a fee for what they sell you, run away.
Watch out.
Run away. Only deal with people who are being paid by you for their time, who have no financial interest in whether you buy anything or what you buy. If anybody has a financial interest in what you buy or what you invest in, run as fast as your aged legs will carry you.
And you have the right to ask any agent for any kind of insurance.
That's right. In fact, there's a form. There's an issue. It's called the fiduciary duty.
Yep.
And you may have heard recently about some Labor Department regulations requiring those who provide financial services to people who have retirement plans adhere to the fiduciary standard and the dealings with those people. And there's a form which any reputable investment or advisor, I believe it's called the DVV, or I think it's called DVV, I don't remember exactly, but it's a form you can find probably on the Securities and Exchange Commission website or on the National Association of State Securities Administrators. And if they won't give you that form, it tells you what standard they apply to. If they won't give you that form, like I say, run, or if you can't run, crawl, or roll, or whatever you have to do, but get out.
I'm getting there.
Anything else?
I have one question.
Who's that?
Is there any, this is Claude again. And is there any type of Medicare supplement plan that pays for coverage outside of the United States?
Absolutely not, and that's because Medicare does not cover any services outside the U.S.
But Kaiser does.
Except in some couple of very special circumstances. And Steve, what were you going to say?
The Kaiser supplement does.
Well, only in limited circumstances. The Medicare Kaiser, very limited, but the other Kaisers may cover more.
The Medicare supplement is what I had in mind. I've just been checking on that because we're going abroad in a couple of weeks. I want to make sure we be covered. And
well, you check into what the details are. We suggest that people check the very extreme details on what and when and how they will cover. And you may find out it's better to buy some of that cheap travel insurance.
yeah, they have something on their website called a Medicare Travel Kit.
Excellent.
Good, we should look at it.
Good. Thank you.
Thank you for your presentation.
Thank you all very much.
We're by the door. Over by the door.
Coming. I'm coming.
And I'm going on vacation in Texas, and I have to be dialyzed. Will my Medicare
the Medicare for, United States, will it be honored there?
Yes, but you have to make prior arrangements before you get there.
Okay. How many months ahead do I have to make arrangements like?
A quarter, 6 weeks, I would say.
So if I get sick in another state, then my Medicare will be honored?
Your Medicare will. Your Medicare
Thank you so much,
maybe.
Steve. Thank you.
Okay, because is it because the state of California is a Medicare supplement?
No, there's all kinds of different regulations, so you need to call and get details.
Okay, thank you.
Okay, anybody else?
Steve, good job.
Oh, you too. You too. Thank you.
All right, let me see. Steve, what are you?
Not that many people left.
I know. All right, we are wrapping up here, and I just want to thank all of our wonderful volunteers one more time, and these 3 exceptional experts, Steve Mendelssohn, Diana Gray, and Dazelle Mallory. There we go, I got all 3 names. Good. So again, let's sign up early and with intention for the next session, which is on May 19th.
Jenna, talk about the evaluations.
Well, yes, once again, we desperately need these evaluations filled out and returned. This is really important data for this program. We want your ideas for future self-advocacy topics because we think that there's a need to continue this. We can delve deeper on some, but there's workplace, for example. We got lots to talk about advocacy in the workplace, but please let us know.
Right, plus the funders like you.
The funding, definitely want. This is all about the funding. And may I just say that David Mondel has worked indefatigably and incredibly well to move us towards an era where we are actually getting the funding that we desperately deserve in ever-increasing quantities. And data. It's all about the data. So we're all a part of that data collection. So let's take our evaluation responsibility seriously. Yes?
Yeah.
All right.
And thank you for letting me get my exercise running
Yes.
around.